And we're live. You're on mute.
Thank you. Good morning, everyone. Welcome to this webinar that's co-sponsored by the ACC, SCAI, and the PERT Consortium. We have a number of esteemed panelists here. If you don't mind pulling up that slide, Michael. So my name's Michael Young. I'm an interventional cardiologist at Dartmouth-Hitchcock Medical Center with focus on structural and peripheral vascular interventions. We have Dr. Sanjam Sethi, who is the director of the Pulmonary Embolism Response Team at Columbia. We will soon be joined by Dr. Rachel Rosofsky, who's an associate professor of medicine for Harvard Medical School. She's a practicing hematologist and one of the leaders for the MGH PERT program. She's also the president-elect for the PERT Consortium. Dr. Khalik joins us from Montefiore in New York. She's the director of endovascular intervention there. Dr. Abudaya is also an endovascular specialist and interventional cardiologist at UAB down south. Our presenters will be Dr. Ritika Verma, who is a vascular medicine fellow at Dartmouth-Hitchcock Medical Center, and Dr. Ijeoma, who's an endovascular and vascular medicine fellow at the MGH. So we'll start with Dr. Verma here. We'll leave some time for panel discussion, and the focus of our talk here will be on PERT systems of care and how do we deploy and institutionalize a PERT program to help better deliver care to our PE patients. So go ahead, Dr. Verma.
Thank you. All right. Give me just 1 second. Okay, so I'm Ritika Verma. I'm a fellow at Dartmouth-Hitchcock Medical Center. Today our topic is Pulmonary Embolism Response Theme, and that is what I'll be talking about with focus on systems of care. So the objectives are just a brief introduction to PERT. I'll also be talking about the protocols we have at Dartmouth Health for acute PE patients, and then we'll be reviewing some cases. So what is PERT? The Pulmonary Embolism Response Team is a multidisciplinary approach to health management of high-risk and selected patients with intermediate high-risk PE. The European Society of Cardiology 2019 guidelines actually gave this a class 2A level C recommendation. The purpose of this team is to talk in real time, just because these cases are very time sensitive. The patients need urgent care, emergent care, so that enhances clinical decision making. I also included a cascade of instability here, which highlights the need for escalation of treatment based on the hemodynamics that we encounter, and the response to treatment is one of the major factors that would guide the treatment. So these are some images that tables, important ones that I got from a recent paper that was published. The references down there if you want to take a look. This is because PE can present in different forms with different levels of acuity. So this is how we risk stratify them. So we risk stratify based on clinical parameters, hemodynamic parameters, lab workup, and imaging. So this kind of goes through all of that, the clinical imaging and the lab factors that are important. We also should know when to escalate care. There are some patients who would need that. So I included a table which talks about indications for catheter-directed therapies. It's just helpful to know what would be the indications. This is another flow chart that gives us a stepwise approach for catheter-directed therapies, it all depends on the presenting features and then how they respond to treatment, and just step up in treatment when needed. So different programs have different workflows for PERT, and based on the complexity and the variability of the presentation, institutions have come up with a systemized approach based on the PERT Consortium initiative. And MGH is where the PERT Consortium actually originated from. So this is their PERT workflow. We also have the NYU's PERT workflow, and then Vanderbilt's workflow. This is a study which has this graph which kind of highlights how the patient survival has improved in the PERT era. And it's basically from the systematic approach that comes with PERT that has helped us achieve this. Now, these are some slides that Dr. Sethi shared with us, and it again highlights how the PERT programs have reduced mortality. I would like to request Dr. Sethi to talk a little bit about these slides, and I can just change the slide whenever you want to go to the next one, Dr. Sethi.
I mean, I think the idea is that, with the wonderful initiative that the PERT Consortium started by creating sort of team-based care, it's modeled on some of the other team-based approaches that we have in medicine, whether it be for valve disease or aortic disease or et cetera. And this was data actually from University Hospital's case, where basically they did a retrospective analysis looking at patients who either qualified for PERT and they were not called versus patients who were qualified for PERT and they were called, meaning patients who are sort of more higher risk patients, at least intermediate risk patients and above. And what they found was that 30-day mortality was lower in the PERT group, major bleeding was the same, and readmissions were also lower, and that persisted out to 90 days. And if you go to the next slide, this is our data that was presented at the PERT Consortium. If you go to the next slide. And we did a very similar analysis. So this analysis was from 2016 to 2019. One of my residents, actually, Dan Snyder, did a great job putting this together. And basically what you found was that or at least what we found, is that if we were called on the patient, and that was patients who at least had some degree of RV dysfunction, there was a decrease in length of stay, a decrease in pag-red-cell requirement, decrease in hospitalization, and decrease in bleeding. Now, again, there's going to be some, because of the retrospective nature of this data, there's going to be some inherent bias in the patients that we're called about, et cetera. But it does give some signal that by calling a PERT team, you are actually affecting important clinical outcomes. And I think the length of stay in particular has been shown really across all of the different data that's been out there. And I think that makes a lot of sense, right? If you can bring people together faster in a more cohesive way, you're going to create decisions or make decisions on a much faster scale. If you go to the next slide, this was a bivariate analysis. And then when we did multivariate analysis, we found that those cases that had PERT experience were much more likely to have less in-hospital mortality, and again, length of stay decrease. So even in the multivariate comparison, where you sort of try to control for pathogen, control for malignancy and other things, it still bore out. So it's just something that's the data that we presented.
Thank you, Dr. Sethi. So we discussed the different flowcharts at other institutions. Now talking about the PERT at Dartmouth. Dartmouth is very unique in its location. I included the map just so you could get an idea of the catchment area that we have. It's a very broad catchment area for patients. We get patients all the way from northern Vermont to just like north of Massachusetts. And some of these places are really small hospitals who don't have echo. there may not be physicians, there may be physician assistants and nurse practitioners taking care of such patients. So we get a lot of transfers from these smaller hospitals who don't really know how to deal with acute PE very effectively. So this is when our PERT teams get activated to when we get a transfer from outside. So the PERT at Dartmouth, it includes vascular medicine, general cardiology fellows, interventional cardiology, interventional radiology, pulmonology, critical care, and CD surgery. In some cases, we have also brought hematology in this team whenever needed. So this is Dr. Stanislaw Henkin, and he runs the vascular medicine and the acute PE program at Dartmouth. I work with him directly, and I've learned a lot from him. And this is what he tells us fellows what the role of PERT is. Coordinating everything, therapeutic options, providing follow-up, that all comes with PERT. Now, I was going to share some protocols that we have at PERT, at Dartmouth, the PERT protocols. This is something that we post in our emergency department. This is just to help guide the providers in the ER to how to manage these patients, when to get us involved. It kind of gives them an idea. This is a very busy slide, I know, but this is just for to give you an idea how the protocol works. This is something similar that we post in the inpatient setting, just so the teams know when to call us, when to transfer patients to cardiology, when to transfer patients to the cardiac intensive care if needed. So we've talked about a lot of protocols, and now I thought I would turn it over to the panel and see if we would just want to discuss how you go about it, how the PERT at your institution works.
Yeah, this is great, Ritka. Just a fantastic presentation of the data, and also just an institutional representation of what you're doing locally. I guess we have a nice mix of physicians here who practice in different settings. Dr. Khalik, perhaps maybe you can start and talk about in a very urban, densely populated, busy city area. How do you guys employ PERT in your institution?
So actually, it is a very timely time that, it's very timely that I was a part of this panel, because I've just moved institutions, and I was at Lenox Hill before, where we had a very well-run PERT program. And, I was a part of Northwell is like, it's multiple hospitals, massive, one of the biggest health systems in New York. And we had a lot of feeder hospitals who would feed us PERT cases. I was at Lenox Hill, which is in Manhattan. And, so as Sanjam would tell you, that it's not so much just the local area. We also, we had a lot of like feeders who would send us PERT patients, and so it would, the inter-institutional transfers would also be a major part of our of the cases we did. So essentially, it all developed almost I think around the same time as COVID came about. And we started getting a lot of PE patients, and there wasn't any system in place from the very get-go how to take care of these patients. So essentially, what we developed is we kind of developed a very similar approach as what Ritika was showing. Is basically got ER involved. Actually, the head of our PERT at that time was our or still is. He's the chief of pulmonary medicine, who was kind of what we call the PERT leader. And we also had, we multiple disciplines to call. It included us, interventional cardiology, structural, and which is basically under CT surgery's premise, and vascular and IR. So essentially, whenever ER activated a PERT which met certain criterion, which was, anything less than a low risk PE, they would call pulmonary, and pulmonary would, we would get on a quick phone call, whoever was available at that time, and, or do a quick Zoom and basically decide what was the best case approach for that patient. And we were at that time a part of the trials, mostly in RE trials, so flash and flame. So accordingly, and I think now they are basically, we would decide at that point what would be the best case scenario, and most of the times end up taking to the lab when appropriate. And essentially we it made the process extremely streamlined, and even the transfers we would get done within like 6 to 8 hours of the case presenting. And again, because CT surgery was a part of the program, so we had access to, ECMO, protective, duo, all that stuff. Although we have never had to use one, but we had access to all of that as well. So then, so that's basically my 2 cents. And the way I say it is the segue is because I have now joined the new health system, which is, I did some basic analysis. We have 700 PE cases come through the ER with the, I don't mean to say that they're all massive PEs or submassive, but there is no PERT program in place where I am right now. So that's why I think it's a great opportunity for me to learn how you guys are doing it as well.
That's fantastic. Thanks for sharing that. We do have a question in the chat, but maybe Hussein, if you want to start, and then I'll turn it to you, to Sanjam, maybe to address the question in the chat. How do you guys do it down at UAB?
Sure. So, I mean, like probably, Ritika presented and just Asma actually talked about, when you're probably the largest academic tertiary center in a state, and we get actually even referrals from nearby states. We were lucky actually that we've been having a PERT team protocol for the past at least 2 years. It doesn't involve as much specialties, as you presented initially for the initial call. So the initial discussion is usually between the PERT attending on call. So I'll actually let me walk by how, like, when the patient, for example, comes. So there's two ways to present, either as an inpatient, whether it's a referral from outside hospital, or an inpatient, like a patient in the hospital admitted that they discovered a PE, or if it's a patient presenting to the ER. So either way, once a intermediate risk or high risk PE is diagnosed or is suspected, the PERT team basically is paged. There's a MICU fellow and there's a CCU fellow. So the MICU fellow and the CCU fellow both actually respond to the page. They both evaluate the patient, and they present basically the case to the PERT attending covering that call. Right now we have I think 2 pulm critical care attendings covering call, a cardiology attending who's also trained in critical care, who actually is the director of the CCU, who also participates in the call, and then some of the intervention cardiologists actually take PERT call as well. So it's between pulm critical care, cardiology critical care, and intervention cardiology. One of us is covering. They discuss the case, and then we have a nice software. It's like an app on your phone, and it's like a group. We have like a group messaging, HIPAA compliant messaging platform, and we just basically, whoever that attending that got that call or is on covering that night or during that day would basically present the case, upload images, whether it's the CTA scan of the chest or the bedside echo, sometimes hemodynamics, and then there will be like a discussion between us, and whatever the group discussion leads to in terms of management, the case is basically or the results are relayed back to the primary team. But as I said, it's, if we need more specialties, for example, hemonc, we do definitely involve them. We have 1 or 2 hemonc attendings that actually help with seeing patients in clinic for further evaluation. And then if the case requires CV surgery or vascular surgery or something, other specialties, we would definitely involve them. But right now it's mainly intervention cardiology, pulm critical care, and cardiology critical care.
I think it's very interesting how each system is set up a little bit differently. So, at Columbia, we've had a PERT since 2016. Started off as an ECOS console, and then sort of not procedure specific, but actually disease specific. And I think that's really appropriate. And because we've done this for a little bit of longer time, we've sort of tried to streamline things. So at first we would involve everybody, sort of every single discussion, that became a recipe for kind of burnout, because you don't need to wake up people at 2 a.m. to discuss somebody that's clearly going to need medical management, right? And so now we have a fellow that takes in the intake, and then we involve the specialties as needed to come up with the right. And so we have basically a champion or two from each different specialty: cardiac surgery, hematology, interventional cardiology, ECMO team, pulmonary, etc. And we involve them as needed when the case comes in that clearly needs their input or help. So it works actually really, really well that way. I'm going to address a couple of the questions in the chat. So there's 2 questions in the chat. One is, how does our team get activated? Human-dependent activation or AI? And I think AI is certainly the wave of the future, in the sense that it is rapidly being distributed across many different hospital systems. I think you do see a little bit of bias in the panelists here that we're all from big academic institutions. And I think there we have a litany of fellows and residents that end up doing a lot of the activation or a lot of the heavy lifting, especially at off hours. But I think AI, particularly for programs that are either starting or programs that do not have that kind of manpower, is certainly one avenue. And there may even be a utility in centers like ours as well, to streamline and to create faster activations as well as decision making. But I don't know if anybody else had thoughts about that.
I think going to the next question there about radiology as a segue to that, Sanjay, those are all great points as well. In our radiology department, they've done a tremendous job in terms of adding to the interpretation, depending on the PE burden. Obviously, if it's a saddle, if there's massive RV to LV dilation, they'll sometimes write in there, consider, acute PE/PERT activation or consultation. And that also prompts, because that gets forwarded in addition to sort of a warm handoff to the ordering physician, usually an ER resident or attending, which then becomes sort of like a mediates a human-dependent activation. And that's something that could be scaled, quite frankly, to some of our referring centers. I think we, as you mentioned, Sanjay, I think we all operate in sort of this hub and spoke model of care, which is honestly probably the best way to approach some of these more complex patients. But in the interest of time, just so we can get to Dr. Ijioma's presentation, I think, Ritika, you had a couple cases to go through, and then we'll transition over to Ketchy.
Great, thank you. So that was a good discussion. Thank you. Moving forward with the cases. So I started responding to PERT calls not too long ago, but I have had the opportunity to see a lot of interesting cases. Just talking about a few here, my first patient is a 75-year-old male who presented to the ER with dyspnea, both at rest and exertion. Now he had a history of AML, and he received a stem cell transplant just about 6 months ago before he presented. His initial evaluation showed tachycardia, but otherwise his vitals were stable, blood pressure was fine. His labs showed elevated D-dimer, troponin of 1.03, and a pro-BNP of 5,600. This was his CT, which showed a large central PE. This is the echo that we did, which shows RV dilation and post-systolic function. We were also able to appreciate the McConnell sign. So for the management of this patient, the PERT team was activated. He had a high SCAI score, and so Lovenox was started to start with. We did not think he needed any systemic thrombolysis because his vitals were fine. He was hemodynamically stable. So we decided to do a catheter-directed thrombolysis on this patient, and I just included, well, this is the bilateral ECOS catheter that we can see that we use for the thrombolysis. Quickly going to my second case, a 63-year-old male came to the ER after experiencing a syncopal episode. He also complained of dyspnea and chest pain. He was tachycardic on exam, blood pressure was stable. He was hypoxic, needing about 4 liters of supplemental oxygen. Had an elevated white count, troponin was 0.07, and a pro-BNP of 918. So this was his CT, which shows saddle PE very clearly. So we have the echo for this person, which again shows a moderately dilated RV and poor systolic function. PERT team was activated for this patient mainly because he had a high SCAI score of 3, large clot burden, RV dysfunction, and elevated biomarkers. He was started on a Lovenox, and we ultimately decided to go with catheter-directed thrombectomy for this patient. This was the pre-angiogram. Here we can see the catheter, the Inari catheter that was used for clot retrieval. This is the pulmonary angiogram that was done after the thrombectomy on each side, and this is the clot we removed.
Do you have right heart cath numbers from this case?
I don't right now, Dr. Sethi, but I'm sure I can get it to you.
So just to address that question in the chat, I think it's very interesting. This patient had a syncope and an elevated heart rate, extreme tachycardia, and I think that to the point that was made in the chat about are we identifying massive PE? I think PE is a spectrum, right? So we tier it low risk, intermediate risk, and high risk. But the reality is that patients are on a spectrum. So there may be sort of that intermediate risk peaking into high risk, and there may be intermediate risk that's sort of really on the low side. And the ESC guidelines are now separating intermediate high and intermediate low. And what I'm getting at is that there's data from Loyola, Pittsburgh, and UPenn, which suggests that of the patients that you bring to the lab, 40% of those patients actually have a cardiac index of less than 2, suggesting that they're in subclinical shock. So I do agree that this patient could very much be that kind of a patient. So we're very curious about what their cardiac index was, but I wouldn't be surprised if it was a lot lower than we think it is. And there's sort of the compensatory mechanisms are to hang on. I mean, I think we're running short on time here, but the bottom line is that the RV is a volume chamber, not a pressure chamber, and therefore it has a compensatory mechanism, and then it sort of fails abruptly. And I think that's something for us to understand and think about when we think about the hemodynamics of these patients.
Okay.
That's great.
Yeah, thank you.
Go ahead, Ritika. I think we have a minute left for
yeah.
you.
So this is just my last case. 56-year-old female with uterine cancer who came to the ER with worsening peripheral edema and chest pain. Her vitals were, heart rate was fine, blood pressure was stable, but she was hypoxic, needing a supplemental oxygen. White count normal, troponin was normal. She had an elevated BNP at 943. This was her CT, which showed a large right descending pulmonary artery embolism. Her echo was normal. So for her management, again, PERT was activated mostly because of the high SCAI score. For her, two Lovenox was started, and for her, we ultimately decided to go with conservative treatment with systemic anticoagulation. We chose warfarin because of some financial concerns that the patient had. So those were all my cases. I would just like to acknowledge Dr. Henk and Dr. Krieger and others mentioned on the slide. Thank you so much.
Well done, Ritika. Thank you so much. Great discussion so far. We do have a very interesting question from the chat that maybe while Dr. Ijeoma loads her slides next, perhaps Asma or Hussein, did you want to address this? This was from an attendee that says there's a tremendous discrepancy in the guidelines for catheter-directed treatment for submassive. ESC gives a 2A indication. ACC hasn't updated guidelines. What is the strategy that we all should use to get our multidisciplinary partners to sort of buy into the PERT program concept?
Yeah, I mean, I was going to say this is really a very important question, and this is something that we face every day, you know, in our discussions when we discuss the PE cases that we get. And it's not just about catheter-directed, even which modality do you use, you know, catheter-directed thrombolysis versus thrombectomy. So it's not just about you know, systemic thrombolysis versus anticoagulation only versus catheter-directed thrombolysis. It's also, or catheter-directed interventions. It's also which catheter-directed intervention do you do? Do you do, you know, catheter-directed thrombolysis versus thrombectomy? And actually, Ritika, the first case that she presented, I was basically just thinking about that. Like, you know, you guys chose catheter-directed thrombolysis. You could easily you know, argue you could have done thrombectomy given the really large clot burden. So it's you know, unfortunately, and you know, Sanjam and Mike, you can definitely comment more on that. We don't have really very robust evidence in terms of comparing therapies among themselves. I'm talking about catheter-directed interventions. There are clinical trials that actually are undergoing right now. Actually, the FLASH registry just I think was presented in you know, recently they presented their data, and we will have more data coming up also hopefully in the, you know, within the next few years. In our UAB, again, it's a multidisciplinary discussion. We have the interventional cardiologists on board, so you know, our pulmonary or even the cardiology critical care colleagues, they are with us on the call, and we, you know, maybe some, you know, some of us are more biased towards more conservative management. Some of us are more biased towards more, you know, intervening on some of the cases. So that's why it's nice to have this PERT team, because it gives us a balanced sort of, you know, opinions. Now, which guidelines to use? To go back to the question, I mean, the ESC is the most up to date, you know, or the most recent. So you know, hopefully the ACC, you know, I don't know if they're waiting for the newer trials to do that, to update their guidelines, but hopefully they are in the works of doing that. But I think, you know, given the lack of having these up-to-date guidelines being up to date to the data that we have, and while awaiting the new data to come up, I think it's having this PERT. That's why the reason of this talk is that the PERT team is very important in removing, you know, having, like, let's say, just one-sided type of decision making, and having these protocols in place help fill in the gaps of having a clear guideline. So I think that's you know, that's why having a PERT team and the protocols that are developed within each institution is, I think, very important.
That's great. That's great.
So I actually think that's great. You're absolutely right. There's so much equipoise in data, and there's essentially it's a data-free zone, right? Like, we don't know good literature on this. But I also have and at least what worked for us was a slightly different approach. Since we are asking if the pulmonologist would buy into it, this was COVID times, right? And basically everybody who got a catheter-directed thrombectomy essentially was either was not in the ICU. They were going to the floors, tele floors, and they were basically up and out of the hospital, maybe in next day or the day after. So basically, which goes to this slides that Ritika and Sanjum shared about that this being extremely not only safe, less bleeding, and length of stay, I think, was the biggest, which our pulmonology team bought into, the ICU team bought into, was and including the C-suite, that it was very economically feasible for the hospital, and there was a quick turnover, and these patients felt better. Like next day, we did a dyspnea score, like we did a PE quality of life at 4 weeks, and so everybody before discharge got a 6-minute whatever walking test, and they all felt great. And we saw them in week to 2 weeks. These actually pulmonary followed them, and they felt very good. If we had used our traditional modalities, I think they would occupy the hospital beds, as we know, sometimes for 6 days, 7 days, and I honestly think the proof is in the pudding. Like somebody says that the lack of data doesn't mean that the data isn't there. It's just this means that we haven't gotten to it. So yeah, basically, I think that the answer lies in having PERT teams in place, and basically partnering with your pulmonologist and all of what was discussed.
Thanks so much, Asma and Hussein. Really insightful there. Kechi, do you have your slides up ready to go? We just wanted to give you enough time to present here, but really appreciate the thoughts from the panelists there. Not sure if
You're on mute.
Oh, hi, good morning, everyone. Can you see my slides?
Yes,
Yeah.
thank you.
Okay, perfect. Well, thank you so much for this opportunity to present at this webinar. I'll be talking about PERT and the management of PE, and I'll be building on some of the things that my co-presenter has already talked about. So I have no disclosures, and our objectives are basically to review, to discuss the role of the pulmonary embolism response team in the management of acute pulmonary embolism. For the outline of this talk, we'll look at the role of the PERT team in the management of acute PE. We'll discuss the management of acute PE in general, and then we'll look at 3 MGH PERT cases. So what is PERT? We've been talking about this. I think this is kind of redundant, but PERT is basically a multidisciplinary team of experts working together to provide optimal care for patients with PE. And the objectives of the PERT is to respond quickly for the treatment of patients who have massive or submassive PE, and then to leverage the input of a multidisciplinary team of experts to provide the best therapeutic option for each patient, and also to advance the science of PE care through research and education. I think some of the panelists have talked about this. As we get more data from PERT teams, hopefully we can continue to push the boundaries of what's best care, what the best practices for management of pulmonary embolism. The European Society of Cardiology guidelines give this a Class 2A recommendation that a PERTs team, which is a multidisciplinary team or program, should be considered for the management of high or selected intermediate risk PE, depending on the resources and expertise available in each hospital. So Class 2A level evidence C. And so the composition of the PERT group for each hospital may vary depending on what is available, whether it's a large tertiary institution or a community hospital. The PERT consortium was established in 2015 in the US, and the number of states who have PERT teams across the country and are part of this consortium is continuing to grow over the years. Here at Mass General Hospital, our PERT program is a little bit different from what's the other 2 institutions that were described. What happens is that when patients present to MGH, whether in the emergency department or on the floor, the PERT activation goes directly to the PERT fellow, who is one of the vascular fellows or vascular intervention fellows, and then that fellow then goes to evaluate the patient. And then at based on the evaluation, clinical evaluation by the vascular fellow, who is usually one of the interventional cardiology fellow who's doing advanced training, or an internal medicine fellow who's just doing pure vascular medicine. The patients are classified into low risk, intermediate, or high risk patients. And then if it's intermediate or high risk patients, the PERT multidisciplinary team is then activated, and a meeting is held virtually with all the members of the group team who are able to participate. And during the group meeting, then a decision is made as to what is the best type of therapeutic option for the patient in question. Other members of the team, they're not members of the PERTs group team, can also be invited, include the primary service taking care of the patient and any other relevant services that we think the input is required or it will be invaluable. So just for a quick overview for fellows who are listening, acute pulmonary embolism, behind MI and stroke, venous thromboembolism is the third most frequent acute cardiovascular syndrome. And over the past several years, studies globally have shown that the incidence of PE has been increasing globally. However, the case fatality rate has been decreasing, and this has been thought to be due to improved treatment options, a quick diagnosis of patients with PE. Patients can get PE if there's several predisposing factors, which include fractures, lower limb fractures, knee replacement surgeries, which are considered strong risk factors, and other weak risk factors include bed rest, immobility, increasing age, or varicose veins. From our days of medical school, remember Virchow's triad in the pathophysiology of thrombus. So stasis, venous injury, and hypercoagulable state all contribute to the development of thrombus. And the presence of PE leads to increased RV afterload, and that eventually causes the neurohormonal activation to occur, and that increases RV oxygen demand, leading to eventually decreased RV contractility. And this spiral eventually leads to reduced cardiac output, and eventually, if it's not stopped, can lead to death from obstructive shock. Our ACC guidelines have been updated, but the European guidelines have a diagnostic algorithm that's recommended for diagnosing acute PE. If the patient is unstable hemodynamically, the first imaging modality is recommended as a bedside echo. If the echo shows no evidence of RV dysfunction, then you should search for other causes of shock. If the patient is on the echo is found to have RV dysfunction, and if CTP protocol can be done, whether it's available and feasible, then you should get it. And if the CTP protocol is positive for PE, then you should treat for high risk PE. If the CTP protocol is negative, then other causes of shock should be evaluated and treated. Patient who has a suspected PE and is stable, then the algorithm for diagnosis starts with clinical judgment. What's the clinical probability of PE? If the probability of PE is low, you start with a D-dimer test. And if that is negative, you don't need to do any further evaluation or treatment. If the probability of PE is high, it's a class 3 to do a D-dimer, you should go ahead and do a CTP protocol. And if that is negative, then no further treatment is required. There are many therapeutic options available for treating acute PE, and my co-presenter has gone over most of these: anticoagulation, thrombolysis, mechanical thrombectomy, surgical embolectomy, and adjunctive therapies, IVC filters, and ECMO support. SPECI score, which my co-presenter talked about, is useful in assessing the severity of the acute PE. There's a point assigned for each of these parameters. If the SPECI score is 0, that's been shown to be associated with a low 30-day mortality rate. If the SPECI score is greater than or equal to 1, the 30-day mortality rate has been shown to be about 10.9%. Using the SPECI score and clinical parameters, you can then decide the 4 strata of risk for the patient. The 4 strata are low risk, intermediate low risk, intermediate high, or high risk. High risk patients are patients who are unstable hemodynamically, have evidence of RV dysfunction, whether it's on echo or CT, and have may or may not have other an SPECI score available. Whereas the low risk patients are patients who are stable, SPECI score is 0, there's no evidence of RV dysfunction. The ESC guidelines recommend a algorithm for management of acute PE based on the risk stratification. If the patient is determined to be low risk and there's no other reasons for hospitalization, you can discharge the patient home early on treatment. If the patient is high risk, you should go ahead with reperfusion therapies and hemodynamic support. Intermediate risk patients should be hospitalized and treated. For duration of therapy, just a few words. The recommendation by the guidelines is to anticoagulate for at least 3 months in all patients with PE. And if the patient has antiphospholipid antibody syndrome, indefinite anticoagulation with vitamin K antagonist is recommended, class 1 level of evidence B. So let's look at a couple of PERT cases at MGH and how the PERT team was instrumental in deciding what was the best therapeutic option for the patient. Here's the first case. A 71-year-old man with morbid obesity and atrial fibrillation, not anticoagulation, presented with worsening shortness of breath. Bilateral leg swelling and orthopnea. On vitals, his heart rate was in the 110s, his blood pressure was hypertensive, 208/86, respiratory rates was 22, and he was sat in 95% of room air. His troponins were mildly elevated, but they were flat. Low extremity duplex ultrasound showed acute right popliteal DVT. That's a typo there. And here's his chest CT. You can see there he had a lobar PE in the right lobar arteries, and he actually also had in the left as well. His echo showed evidence of normal RV function. And there was his CT. But of concern, there was an evidence of a mass in the left atrium. You can see that on the CT there. And the question was whether this was a clot in transit versus a true mass in the left atrium. And you can see that also in the echo. You can see that little flicker of a mass coming from the left interatrial septum. So here we have a 71-year-old man with bilateral lobar PE and a left atrial mass concerning for possible clot in transit. What is the best step in the management of his acute PE-associated left atrial mass? Is it to anticoagulate? Is it to do systemic thrombolysis, catheter-directed lysis, mechanical thrombectomy, surgical embolectomy, or to call a PERTs group meeting? You're the vascular fellow evaluating the patient. I'll open it up for the panelists to see what they would think of what to do for this patient.
I think consistent with the theme of our webinar would be to deploy your PERT team and sort of hold a go-to meeting, if you will.
Same. Yeah, agree.
I agree with him, especially with the atrial mass.
Yeah, I think the concept here is that you have multiple specialties that can lead some degree of, depending on what your institution has and what people's interests are, expertise here, right? Because if there is a left atrial thrombus with a PFO, there's surgical options, there's creative catheter-based options, there's systemic options, therapy, and so getting all that input, I think, is very valuable.
You're absolutely right. And consistent with the theme of our meeting, we definitely called a PERT group call. And the group, sorry, my slides are going faster than me. The group recommended evaluation of the left atrial mass with cardiac CT, and that showed a left atrial myxoma. Cardiac surgery evaluated the patient, and the consensus was to proceed with outpatient surgical evaluation after in-hospital treatment of his heart failure and acute PE. So this was a case where the PERT group came to a consensus about how to prioritize the management of the PE and to make sure that coexisting diagnoses, which was the left atrial mass, was not ignored or wrongly attributed to be just simple thrombus. Here's another case, a 55-year-old woman with morbid obesity, double lung transplant, obstructive sleep apnea, and chronic respiratory failure. She presented to the ER with worsening shortness of breath and chest discomfort. She was tachycardic, normal tensive. My slides are running from me. And she was satting 99% on 6 liters of oxygen. Here's her CT. You can see there's evidence of PE in the right segmental and subsegmental arteries. But over here, you can see she had a port from her transplant, lung transplant. You can see there is filling defect there that was concerning for catheter-related SVC thrombus. And here is her echo images. The quality was not very good due to her size and poor windows, but you can see the hint that the RV is working fine. So you have a 55-year-old woman with a right lower lobe PE and catheter-associated SVC thrombus. What is the next best step in the management of her acute PE? I think we've seen the answer. Call a PERT meeting. And this was very invaluable because here we were able to get the input from the oncology, from the transplant team as well. And their recommendation was an anesthesia that the patient was deemed to be a high risk. She was on 6 liters of oxygen despite being a double lung transplant. That she'd be a high risk for anesthesia or sedation complications. So the thought was continue therapeutic anticoagulation, reassess in about 48 hours. And if she didn't have any improvement despite therapeutic anticoagulation, then we can consider doing endovascular interventions for the SVC thrombus. And to my amazement, actually, she got much better on therapeutic anticoagulation, and her oxygen requirements were weaned down to 2 liters of oxygen, and she actually left the hospital on therapeutic anticoagulation without having to treat the SVC thrombus with advanced therapies. So once again, this is another benefit of the PERT team is group meeting is that you get that expertise from different specialties, anesthesia, pulmonology, critical care. We had the transplant team also available at the meeting, and all that expertise came to a good decision regarding her patient care.
These are really fantastic cases, Ketchy. I'll just interject and maybe point out for our audience members, Hussein had also mentioned it in his own program, but one of the challenges of leveraging multidisciplinary services all at once, we see this in the structural heart space, we see this in complex coronary disease, is that we're all busy physicians, right? And to get them all to convene at once for a phone call or a discussion like this can be very difficult to do, particularly when it's in the middle of the night. And so I know at your institution, Ketchy, if you're still using the GoToMeeting platform, different centers have, as long as it's HIPAA compliant and everybody has ready access to it, whether by their phone or their laptop at home or in the hospital. It's a great way to really leverage resources in a very expeditious fashion so you can come to a decision without pulling people out of their, clinic spaces or whatever else they may be doing. But go ahead with your third case, and then we can wrap up with some further discussion with the panelists.
Thank you so much. So this is the third case. We have a 71-year-old woman with HFpEF and newly diagnosed peritoneal carcinomatosis, and she presented with right-sided chest pain. She was tachycardic, blood pressure was a bit soft, 97/64, and she was a bit tachypnic, but sat at 95% of room air. This is her chest CT PE protocol. You can see large thrombus burden in the right main PA as well as the left side. And here are her echo images. You can see her right ventricle is enlarged and is not really moving much. So RV dysfunction, large amount of thrombus bilaterally in the both main PAs, and the patient with borderline soft blood pressures. Her SPSE score is about 4 based on her clinical parameters. So what is the best step in, what's the best step in the management of her acute PE? Anticoagulation, systemic thrombolysis, catheter-directed lysis, mechanical thrombectomy, surgical embolectomy, or call a PERT meeting. And once again, I think everyone will say call a PERT meeting is the theme of our discussion here. And that's what we did. We called a PERT meeting and we discussed the risk-benefit of different therapeutic strategies, including systemic lysis in the setting of her newly diagnosed cancer, metastatic cancer, or performing endovascular interventions, and if we decided to go the route of endovascular interventions, which type of endovascular intervention to choose, or just remaining on therapeutic anticoagulation. And this consensus was to switch from just therapeutic anticoagulation, but to proceed with mechanical thrombectomy, and that's what we did. And she successfully underwent mechanical thrombectomy, and her PA pressures improved there was actually about a 8 millimeters of mercury drop in her mean PA pressures. Yes, it's a huge amount, but she actually started breathing much better the following day after mechanical thrombectomy and has been moved out of the ICU. So in summary, team-based approach is important for the optimal acute PE care, and the PERT group provides interdisciplinary collaborations to streamline care and optimize patient outcomes. Those are the references, especially the ESC guidelines. Our ACC guidelines will be coming up hopefully in the next couple of months. And I want to acknowledge the ACC Interventional and Early Career Section leadership for allowing me this opportunity to present. Thank you.
Thank you. That's really great presentation. And wanted to welcome Dr. Rachel Rosofsky, who had to join us late because she was attending to some emergent patient care responsibilities. And Dr. Rosofsky, welcome to our panel. I wanted to have you comment. There was a question earlier in the chat about how to bring buy-in into the system, into a PERT or into
duty is, I think the nephrologist is. Why is he getting a CT of his legs?
Is he still doing that?
She may still be consulting there.
Yeah.
Anything else you need from us?
But in any case,
Bye-bye.
So
either Rachel.
Well, in any case, I mean, from my standpoint, to comment on that question, I think that we need to be very diligent about enrolling in data. There's 2 randomized control trials now, one looking at heparin versus catheter-directed thrombolysis, another one looking at catheter-directed thrombolysis versus catheter thrombectomy. There's an NIH study that's coming down the road, so we need to generate high-quality data that's going to help convince our colleagues. I shouldn't say convince is the wrong word, but help to understand the field such that we can get the right therapy for the right patient. So we need to be diligent about enrolling in these studies. And I think the focus should not be on, hey, we need to do this new technology or this new thing. It should be, we need to coordinate our care such that the patients are getting the right things. And that would include things like outpatient anticoagulation management. That should also be coordinated amongst hematology or whoever is doing the pulmonary hypertension in your institution and things like that. So I think there's role for team-based care, and I think that's where the buy-in comes from, is understanding that we can improve our outcomes in general. Rachel, thank you for joining. What we were talking about was, there was a question earlier about getting buy-in and how to have the people at your institution buy into the concept of a PERT, and we've had different explanations or perspectives from our panel, but I wanted to hear your thoughts as well.
Oh yeah, I mean, I think the first thing is to pick people that are enthusiastic about this, right? So you got to pick your team wisely. And actually, to just take a step back, I think getting buy-in from leadership is key. And I think there's enough evidence, and I'm so sorry that I was not able to join earlier. I'm just a little crazy here. But there's enough evidence, I think now looking at, I would say there's probably at least a dozen articles out there looking at kind of pre and post PERT. And I think the most recent one, there's been one out of Cleveland, Rochester, Kentucky. The most recent one that came out showed, because it did show kind of decreased 30-day mortality, decreased inpatient in hospital mortality. The most recent one came out that there was a decrease in 6-month mortality. So I think we have evidence that you could bring to your leadership and say, this actually decreases mortality. We know it decreases length of stay. There wasn't one even pre and post that showed decreased costs. So first, to get in buy-in from your leadership, and you can go to pertconsortium.org and you can reach out to us and say, contact us. We can help you actually start a PERT. We have something called a PERT Partners. So any institution, and I encourage fellows to do this. I mean, some people in our leadership now started off as fellows. So really important to get involved as fellows. but go to pertconsortium.org. You can just hit, question or whatever, contact us, put your information in, we'll contact you. We can send you, we actually have compiled about 15 of these articles that you can read, share with your leadership. So number one, get buy-in from your leadership. Once you get buy-in from your leadership, I think it gets a lot easier. Then I would pick your team carefully and pick people that are enthusiastic and interested in this. And then you want to make sure, actually, sometimes people can get something out of it too. So for example, a lot of places will say, we don't really have a hematologist. I'm a hematologist. And I say, well, maybe you offer the outpatient follow-up to the hematologist, and maybe they'll get excited about that. So, and I think the way that the other thing is to make sure that people have a stake in it and their voices are heard, and then they can see that they're actually making a difference. I think the way that you set up your PERT is going to depend on the needs and resources of your institution. At Mass General, as Michael knows, embarrassment of riches. I think we have like 15 different specialists, but a lot of times people will put who's ever on call, like pulmonary is on call, then they're going to be on call for the PERT team. So it's not an added like on call that people need to do. And then I would say that you need to frequently kind of get your group together and figure out what's working and what's not working. Because a lot of times once you start it, you want to make sure that you're working out the kinks, and is it going to be 24/7, and who's taking the first call? Is it a fellow? Do you have fellows? Is it all attendings? Things like that. And then, there's a guy in New York who actually takes his PERT team out to dinner once a month. So to thank them, or you can get PERT swag, you make little pencils or whatever, something to, just let people know that you do appreciate them. I think that's important to do. But I would really encourage everybody to go to the PERT Consortium. If you don't already have one, you can register your PERT too. We have the PERT database, which now has over 8,000 patients in it. It's the largest PE specific database. So that's important. Again, sorry I wasn't able to hear the calls, but I think even more important, I was listening to the tail end of the last two. Obviously call a PERT, but equally as important as that is that you have to start anticoagulation before you start PERT, before you call PERT. And this article that I just mentioned that showed the 6-month mortality rate, this is shocking what they found. They found that the risk of mortality was reduced by 5% for each hour earlier that the diagnosis of a PE was made. So first of all, make sure PE is on your differential. But there's also lots of studies that show early anticoagulation saves lives. So I think it's equally as important to just make sure. A lot of times people suddenly have a PERT and everybody's like, wow, I don't have to do anything until I hear back from the PERT person. And Michael, we had some of these at Mass General. We'd be like, no. Start the anticoagulation, then call it. Don't wait for us to call you back. And then we can make a difference. And I think I heard at the tail end, I think the most complicated patients are those that are in that intermediate risk, especially those intermediate high. I think there's still equipoise about what to do for these patients, catheter-directed thrombectomy, catheter-directed thrombolysis, anticoagulation alone. And I think I heard somebody say there's 6 or 7 trials now looking at this. There's some randomized control trials. I think we're really going to learn from these. And I encourage your institution, if you're not already involved in one of these trials, you can go to PERT Consortium. We're involved in a lot of them. And we can help you decide if you want to be involved in one of those, and connect you with whichever one you want to do. And I think that's really going to help us move the field forward. I would also say, I'm not sure the population, but I'm guessing it's a lot of trainees, fellows, right, that are listening. I would say get involved with PERT, and you will have incredible opportunities for leadership. I will say 2 of the heads of 2 of our committees used to be fellows, like less than 4 or 5 years ago. It's a great opportunity to really learn, but also to collaborate with people literally from all over the world. And so this can really help, and also you'll be part of something really big. We recently collaborated with the FDA. So we've been meeting with the FDA for the past 2 years. We had a big meeting in April. We brought every single key stakeholder that has to do with PE. So industry, patient organizations, sister organizations, patients, and then the FDA and CDER. And we are creating a set of elements that we think should be collected for anybody with a PE, both clinical trials and in practice. And that's going to really change how we are able to study this, as well as how we're able to deliver care. So again, there's such opportunity for you. There's lots of committees. There's a research committee, education committee, clinical protocols committee, communication committee. You can get involved in writing papers. You can submit a proposal for the database. You can get involved in webinars. You can get involved in education. We're writing reviews. There's just so much that you can do. We're actually launching a centers of excellence that you can get involved in. So there's just incredible opportunity. The future of, I think, medicine and more specifically PERT is the trainees. And this would go nowhere, I think, without all of you. We have our 9th annual Pulmonary Embolism Symposium. Trainees fellows are free, so you can come for free. It's going to be in Austin. We also have a trainee boot camp. It's already filled up for this year, but I would encourage you to be on the lookout for that. We have 70 fellows signed up for our boot camp in April. It was supposed to be in our annual meeting. And so you can register for that. We also have abstracts. You have an opportunity to present your research. So again, I cannot say enough of amazing opportunities for you. And I really do think that this team changes care. And I already shared with you a little bit, and happy to share with you more of that data. I know that's kind of a long-winded.
No, Rachel, thank you so much for joining. I know how busy, we all realize how busy you are, and I should mention that I believe you're the president-elect for the PERT Consortium this coming year, so we'll definitely benefit from your leadership going forward. I know we're over the hour, but that's okay. We'll just end with just final thoughts.
Wait, Michael, can I make one more plug? We do have one of the other things, and I think in cardiology in particular, there's a dearth of women. And so if you are a female, we actually have a climb program. We're really excited about elevating women and getting women into leadership positions. So if you're interested in that, you can join that. And that's also been incredible. We had, I think, 25 people do it last year. And it's really been amazing, again, trying to get women more into leadership roles and moving the field forward. So I encourage everybody to apply for that too. Sorry.
Fantastic. And we have a couple of our presenters here and a few panelists that I think would be surefire early volunteers perhaps. But I would just say to end, and I'll hand it over to Sanjam in case Hussein or Asma, I would say feel free to interject if you have some final thoughts. The one point that Rachel mentioned here that I thought was important too is the continuity of care. So my partner, Dr. Hankin, he sees all of these PE patients in outpatient follow-up, even after activation, despite what therapies they get, just so they don't slip through the cracks. And I think that's just so important, but really would commend the presenters for the fantastic discussion, slides, didactics, and cases. Hussein, Asma, any last thoughts here?
No, sorry. Go ahead, Hussein.
No, go.
So no, I was just going to echo Rachel's thoughts for the final plug of, I think PERT Consortium is doing amazing things, and I'm actually going to reach out to them myself for the programmatic growth and program building, and I'll be reaching out at the PERT Consortium. What is it? PERT Consortium Partners?
PERTconsortium.org.
Okay, no, but the partners where you're helping us.
PERT partners. Yeah, so if you go to PERTconsortium.org, it says contact us. You can just write interested in PERT partners, or interested in starting a PERT, or interested in learning more about, and then we'll contact you, and then we'll set you up with someone.
Excellent. Thank you very much.
Yeah, I think it's like the PERT founders, right? I mean, the founding members, and then you have the partners, or right, like the programs who actually joined after the founding of the PERT Consortium. I mean, I think Rachel did a fantastic job, telling the audience about the PERT Consortium. And she mentioned something specifically about the hematologists. So we have actually the hematology as partners in our team, not necessarily as part of the PERT team, the on-call, like making the acute decision, but actually for the follow-up. So, like Mike was mentioning, the continuity of care and who follows these patients afterwards. We almost all PE patients actually get followed by one of two hematologists that basically have showed interest in managing PE. So we have them as well as, let's say, if someone had any intervention on, like any PE, catheter directed intervention, actually is followed by the intervention cardiologist who did the procedure. And then those who didn't have will either follow with primary care or the pulmonologist who actually saw them. So there is definitely continuity of care. And I think, it doesn't have to be all, all specialties or, all teams involved in the acute process of the decision making when the patient first presents. But it is helpful to have them as the broader, basically, group of teams actually taking care of them and ensuring that the continuity of care follows even as an outpatient as well.
I think this has been a really great discussion talking about how to expand our systems of care, how to create a system that gets the right treatment for the right patient. And we're doing all of those things hopefully through the help of the PERT consortium and things like that to not only have programmatic building, but also expand the research such that we're know and measuring our own outcomes. So this has really been a great session, and I appreciate the presenters and the panelists for all of their thoughts. We've gone through the PERT consortium slides already, so appreciate Rachel walking us through those, and really encourage you all to join. This has been a collaboration with ACC and SCAI and PERTs for this meeting, and on the next meeting, it'll be a collaboration with ACC and SCAI for a Cath case webinar, coronary chip, radial femoral, and alternate access, including large bores. So Saturday, November 19th, 10 a.m. Please join us if you're able to. If there aren't any other closing remarks, I appreciate everybody for their time joining us on a Saturday. I appreciate all the attendees. I know we're a little bit over, but I think this session was really chock full of great information. So I appreciate all of you on a Saturday morning. Thank you.
Thank you for having us. Thanks a lot, everybody.
Thank you so much.
All right, take care, everyone. Good to see you, Rachel. Bye.